Hi, good afternoon. John Snyder here for another edition of Thursday afternoon Newton-Wellesley Medical Group Lunch and Learn. We're excited to have Dr. Lori Katz here to be talking to us about meniscus tears, fix or forget. Next slide, Lori, please, if you can. So as you guys know, we like to tease the upcoming Lunch and Learns. And here's a slide over the next couple of weeks, just a heads up on school vacation week, which is the 15th. We will not be having our Lunch and Learn, but you can see next week concussions. Doug Camo is going to be talking about that, as well as we have urinary fecal incontinence, and then evaluation and management of epilepsy. As everyone knows, these talks are all archived up on YouTube if you want to catch one that you've missed. Next slide. So two real quick things I want to say before I let Lori take over. One is there is an online coaching physical training for all individuals and groups that is funded by our physician wellness grant, but it's actually for any physician or any APP on our medical staff, not just medical group. This is a free benefit for free coaching, free training from our very own Daniel Destin and the rest of his staff at the Shipley Fitness Center. So please take advantage of it. We have this money and it's carved out, and you can do an online coaching and a physical training. It's really cool. And just email Daniel. He'd be happy to set you up. Next slide. Further, there's a drop-in yoga class that's free from Peter Kelly, who's a certified yoga instructor. That happens Wednesday evenings, 5:15 to 6:15. That's on Zoom. The link is in this slide deck here. And then following slide. And then lastly, we want to remind folks the Physician Wellness Initiative also sponsors the virtual meditations that happen on Thursday evenings. We did push the time back due to feedback from you guys, 5:30 to 6. That's, again, just a drop-in Dan Rodman meditation. Next. And I'll leave it up to Lori. Thanks, Lori, for being here. You just have to, there you go. Thank you.
You're welcome. Thank you guys for having me. You did that quick, so we'll hopefully have lots of time for questions at the end. But I thought a topic that I would talk to you about is meniscus tears and whether we should be fixing them or sometimes forgetting about them in certain patients. Hang on one second, one advance. There we go. So just a little bit about me. I'm board certified in orthopedic surgery. I did a sports medicine fellowship at New England Baptist Hospital. I also hold a subspecialty certificate in orthopedic sports medicine, and my specialty is arthroscopic surgery of the shoulder and knee. My office, I'm part of Newton-Wellesley Orthopedic Associates. We have 3 locations. One is at Newton-Wellesley Hospital. 2 are just down the street in Wellesley. We have x-rays in all of our offices on site, so easy to make patient care efficient. For referrals, I have the phone number listed if anyone needs it. And if you'd like to place a referral through Epic, you can do so by putting an ambulatory referral to Newton-Wellesley Hospital Orthopedics. And then you can just choose the provider. And if you want to send a patient to me, you can just choose my name. So a quick overview of what we're going to discuss today. So we're going to talk about the anatomy of the meniscus, but really specifically how it applies to how we treat the meniscus and why we treat it differently in certain cases. Then we're going to talk a little bit about the history, the physical exam, imaging, and the treatment, but we're going to do so by the use of cases because I thought that might be a little bit more interesting. So as far as the anatomy goes, the most basic anatomy is that these are C-shaped cartilaginous structures. They've got both bony and capsular attachments. So they attach to the bone in the root areas, so the back and the front, and then everything else is actually just attached to the capsule of the joint. We've got one on the medial and one on the lateral side of the knee. So the blood supply is really the most important anatomic feature when we talk about how we treat meniscus tears. So when we're born, our meniscus is fully vascular. So the entire thing has a blood supply. By the time we're 9 months old, that blood supply has actually shrunken to only include the outer 2/3 of the meniscus. By the time we're 10 years old, only the outer 10 to 30% has a blood supply, and that holds steady for the rest of our lives. So if you look at this cartoon picture over here, we talk about 3 zones of the meniscus. So that outer 10 to 30% is called the red zone because that's the part that actually has a blood supply. The rest of it, the inner portion, is called the white zone because it's avascular. And so the thought is that it has very little capability of actually healing, even if something is repaired. And then there's the marginal area, which we call the red-white zone. So in this area, it's possible that things might have healing capability, but not always. So we'll talk a little bit about these terms, especially in one of our cases that's coming up. Another important part of the anatomy is, what is the meniscus for and why do we need to try to fix it? Well, initially they thought that the meniscus was a non-functional remnant of a leg muscle. So probably before I was born, if someone had a meniscus tear, they just took out the meniscus. They thought it was kind of like the appendix, you didn't really need it. And then they noticed that these people were getting really bad arthritis and much quicker than they should have been. So that led to extensive research about what does the meniscus really do. So we now know that the meniscus has quite a few functions, the most important being load sharing and reducing contact stresses in the knee. Another function is shock absorption, and then it can also act as a passive stabilizer, especially in patients who don't have an ACL. So if you look at this cartoon picture to the right here, it's a little bit of an oversimplification, but the convexity of the femur, the way it's shaped, you would have a contact stress right here that would take the brunt of all of the force. And then the sides wouldn't really contribute to weight bearing or shock absorption. So the meniscus kind of fills the gap and kind of fills that space so that it spreads the forces evenly throughout the entire femur and tibia. Another important part of the anatomy in regards to how we treat meniscus tears is the tear patterns. So starting from the left side of this picture, the radial and oblique tears are pretty straightforward. It's just a simple slit in the meniscus. These tend not to cause as much mechanical symptoms like clicking or catching, although they can. They can cause pain. They don't always, as we'll talk a little bit more about later. Then we get into these flap tears or the parrot beak tears. And you can tell that flap there, you could imagine it moving around, being unstable. Those tend to cause more mechanical symptoms. Then we have the vertical longitudinal tear here. These mainly happen in adolescents and young adults. And the important thing about these is they tend to occur more in the red-white or red-red region. So these are the ones that have more of an ability to actually repair rather than just resect. The bucket handle tear is the propagation of the vertical tear where that piece becomes so unstable that it actually flips over and gets stuck in the notch. And then finally, we have the complex or the degenerative tears, which generally happen in older patients or in patients with arthritis. So the first case that we're going to talk about today is a patient of mine who is a 21-year-old female soccer player. She twisted her right knee during soccer practice. She felt immediate pain, noted swelling, and she had decreased range of motion. When I examined her, she had an effusion. She lacked approximately 10 degrees of extension, and her flexion was limited to 110 degrees. She had focal medial joint line tenderness, and her ligament exam felt stable throughout. I did get x-rays, which were unremarkable, and then the plan was to order an MRI. So her MRI actually shows the pathognomonic findings for a bucket handle meniscus tear. So the top image is a sagittal cut. So we're looking at it from the side. And if you can see where her PCL is here, and it looks like she's got two PCLs. So we call this a double PCL sign. And what the bottom one is actually that flipped fragment of the meniscus where it's flipped over into the notch region. So when you see a double PCL sign, that again is suggestive of a bucket handle meniscus tear. Then the bottom image is actually a coronal cut. So two things. One is the medial meniscus here looks a lot smaller than it should. So that rest of that meniscus has to be somewhere. And if you follow to the second arrow, you can again see that piece that's flipped over into the notch. So what am I going to do for this? I'm definitely going to fix this and actually literally fix it, try to repair it. And why am I going to do that? Well, she's got a mechanical block to extension. The biggest issue with these bucket handle tears is they generally block the patient's ability to fully straighten their knee, although not always. But that's never going to improve unless you get that fragment out of that notch. There's also the chance that I could save her meniscus if I can actually repair it. And that in turn can decrease her risk for arthritis. So these are actually intraoperative pictures from her surgery. So the picture on the left, up above is the femur, below is the tibia. And what we're seeing in between is that flipped fragment of meniscus that's kind of wedged in between. I put a little character of it below just so you can kind of get a sense that this is the fragment here that we're seeing wedged in between the femur and the tibia. So the way that I treat this is I actually reduce the meniscus back into its normal position, and then I can try to sew it together if I think it's got a chance of healing. So here's after I was done, and you can see back here, these are actually stitches that I put in. You can see another one over here. The meniscus isn't perfect because it sometimes gets chewed up a little bit, but generally that doesn't bother patients. And again, you really want to try to save this in a 21-year-old if you can. These actually have about a 20% rate of failure, but we actually accept that high rate of potential failure for the possibility of saving their meniscus because it really can decrease the risk for arthritis. So she's actually doing very well. She's about 3 months out now, full range of motion and no swelling. And now we're just working on getting her strength back to get her back to sports. Our second case today is a 42-year-old male who tweaked his left knee while he was running 4 months before he saw me. He had persistent medial-sided knee pain since that time. He noted intermittent swelling, especially when he tried to do any higher level activities. He especially complained of catching, which he noted more if he did anything that twisted the knee or was hyperflexion. And that's actually pretty common with meniscus tears. They tend to bother people more with twisting or when you bend the knee all the way as the meniscus gets pinched. He's tried rest, ice, and anti-inflammatories without resolution, and he's been unable to run due to his pain. On physical exam, he had a trace of fusion. He had full range of motion. He had pain at the extreme of flexion, which again can be seen in meniscus tears due to it being pinched. He had focal medial joint line tenderness. And that's actually, in my opinion, one of the most sensitive tests, but by no means specific. I actually think it's much more reliable than the McMurray's test or the Apley-Grind test. Those actually have shown very poor reliability. So the initial studies were great, but follow-up studies showed they were not as good as people thought. And I think joint line tenderness is really one of the best. His ligament exam was stable throughout. I got x-rays, which at his age, definitely you want to get. And you always want to get weight-bearing views, because if you get non-weight-bearing views, you may not get the whole story for arthritis. And the other thing that's actually important is if you do get weight-bearing films, you want to get both an AP and a 45-degree flexion PA view. Most of us tend to wear down our cartilage in the posterior aspect of the femur, and you won't see that unless you get the flexion PA view. So that's really critical. And obviously you want to get the standard lateral and sunrise views. So on his radiographs, I did not see any significant joint space narrowing. I did not see any marginal osteophytes. Given the longevity of his symptoms, I did opt to get an MRI. The MRI showed a trace of fusion, and it showed a medial meniscus tear. So if you see where the arrow is pointing, you can see the white signal in the posterior horn of the medial meniscus. And the most important thing is it has to actually exit either the bottom or the top of the meniscus. If you just see a white signal within the meniscus, that's just degeneration. But an actual tear will extend to the periphery, which this one does. He had no other abnormalities, no ligament injury, and no cartilage injury. So in this situation, I actually think it's probably best to fix it. You certainly could try physical therapy since he hasn't done that yet, but he is having mechanical symptoms, which are fairly constant, and physical therapy is unlikely to take care of that problem. So the reason I chose to fix it, other than the mechanical symptoms, was this was an acute event. He has had symptoms for 4 months. He's still having swelling, and I didn't see any other source of his pain. So no significant arthritis, no ligament injuries. So he did choose to have surgery, and these are intraoperative pictures. In the top left picture, you can see the femur up above, the tibia below, and then the meniscus in between. You can see there's basically a slit, an oblique slit in his meniscus. And here's me using a probe to show how I can actually flip that piece out. So this is an unstable tear, and generally that's the source of the mechanical clicking and catching. So I cannot repair this. This is actually in the white zone. It will not heal if I put stitches through it. At least we don't think most of them will. And so what we do instead is we just resect the unstable fragment. So the bottom right-hand corner shows the meniscus after I've resected the unstable portion. Just real quick, going back to him. So he's now 2 months out. I just saw him back last week and he's doing great. And he's just got back into running and feels significantly better than before surgery. Our third case, so a 58-year-old female recreational athlete with the insidious onset of left knee pain and swelling for 2 weeks. There was no trauma. She's been resting, icing, and trying anti-inflammatories. She notes occasional clicking in the knee, but that's not a consistent finding. Her pain is both anterior and medial. On physical exam, she has a trace effusion. She has slight decreased flexion. She's got mild medial joint line tenderness. It's a little bit vague. It's not quite so focal. And her ligament exam is stable. So again, I got weight-bearing AP and flexion PA views, as well as a lateral and sunrise view. It shows some mild joint space narrowing, actually on both sides on the medial compartment, although maybe slightly more in the left knee. I don't see any marginal osteophytes. We did end up getting an MRI, and because she wasn't getting better after a few more weeks, she ended up having a meniscus tear. So if you look here, this is a little bit of a different finding, but the tip of the posterior horn seems to be missing here. And so we call that truncated, and that's usually suggestive of a radial tear. She also had some mild medial compartment arthritis. So what are we gonna do with her? Well, there's another part to this story which helped me make my decision. On the axial cuts of her MRI, she actually has a fair amount of arthritis of her patellofemoral joint. So this is her patella and this is her femur. The gray is the cartilage on the lateral facet, and you can see that there's a significant lack of cartilage on her medial facet. So she's got moderate to advanced arthritis there. So in this situation, I'm going to try to forget the meniscus tear if I can. And the reason for that is there's a lack of a discrete event, so this is likely a degenerative tear. She's only been symptomatic for a few weeks, so this may settle down. I usually tell patients, even in traumatic tears, unless there's a mechanical block, to try to give it 4 to 6 weeks because a lot of them may stop bothering people. The other thing that's concerning to me is that she's got anterior knee pain as well as patellofemoral arthritis. So this may actually be the source of her pain. And arthroscopy will not help this. And I definitely make sure every patient of mine knows that if they have arthritis, those symptoms will not get better after an arthroscopic procedure. So what can you do instead, since you don't really want to just forget it? Well, she can modify her activities. She can take anti-inflammatories, try physical therapy, maybe even consider a cortisone injection. If she's still no better despite conservative management, then you can consider surgery, but the patients have to have realistic expectations, again, due to the presence of arthritis. So we did end up doing surgery after a few months of failed conservative management, and this is a picture of her patellofemoral joint. So that's the patella up above and the trochlea, and I always tell my patients it looks like a shag carpet, but this is at least moderate arthritis. So in this particular view, we're not seeing bare bone, but this is at least moderate wear down of her articular cartilage. Then we get into the medial compartment of her knee. So up above is the femur, below is the tibia. You can see the difference in the cartilage compared to the last case where it was pristine. This is her medial meniscus. Again, it's not that discrete flap that we saw or the bucket handle. It just looks chewed up in the back. And when I use my probe to pull back her meniscus, this is actually bare bone. So this is a lot more arthritis than what the MRI and X-ray imaging shows. The picture on the right is after I cleaned up the meniscus, so she no longer has those torn, unstable fragments, but she has the exact same arthritis that she came into the case with. So she's doing moderately well. She actually feels better than she felt before her surgery, but I told her that this is probably not the end to this story, and at some point she may need a knee replacement. Our last case is a 78-year-old active male with the insidious onset of left knee pain 3 months ago. There was no trauma. The pain is diffuse throughout his knee. On exam, he lacks a few degrees of extension. He has about 10 degrees less flexion compared to his other side. I noted slight varus alignment on exam. He had an effusion, and he did have tenderness over the medial joint line. On x-rays, if you look at the left knee here, he's got a fair amount of narrowing of the medial compartment as well as osteophyte formation there. This is that flexion PA view, and you can see how much less joint space there is even on this view compared to the standing AP. And this is again why it's important to get this view as well. MRIs are generally not indicated in this patient, but if you did get one, you would see loss of articular cartilage. You would see these tiny little marginal osteophytes. The meniscus usually gets extruded from the joint and often gets torn, as you can see from the white line in the meniscal fragment. The most concerning thing here to me is this bony edema. This is a red flag for any arthroscopic intervention. It's a sign of advanced arthritis, and that should be a red flag even if the x-rays don't look so bad if you're dealing with a patient with a meniscus tear. So what are we going to do for this gentleman? We are definitely going to forget that meniscus. That's not his issue. So what can we do instead? He can modify his activities, go to physical therapy, take anti-inflammatories. He could consider a cortisone injection, hyaluronic acid injections. Our physiatrists offer regenerative injections to try to help pain. And then the ultimate answer to this could be a total knee replacement. So take home points of this talk: if you do order your own x-rays, obtain weight-bearing AP and 45-degree flexion PA views. Consider initial physical therapy and anti-inflammatories when there's been no trauma and there's no mechanical symptoms present. You should consider a referral to orthopedic surgery when there has been a discrete injury, there is a block to extension, there's mechanical symptoms in the absence of advanced arthritis, or when patients fail to improve despite conservative management. So again, this is just a summary slide of my practice, where we're located and how to send referrals should you want me to see any of your patients, which I'm happy to do.
Thanks, Lori. That was really great. Really great talk about the meniscal injuries. I don't see any questions in the chat. Feel free. We have a couple of minutes to throw any questions you have about knees, or I'm sure Lori would entertain any other questions. I guess while we're waiting, Lori, a couple of questions that come to my mind. Number one, and you didn't talk about this a little bit, but what about bracing for these athletes that you're kind of waiting to see if they get better? What do you generally recommend? You said activity modification. I mean, I think I know what that means, but what about like braces and things like that?
Yeah, so I mean, I always tell them that a brace itself is not going to support the meniscus. There's nothing unstable about their knee. So for meniscal pathology, I tell them that if a brace feels better to wear it. If it doesn't, then don't. So if they want to try like an over-the-counter, either neoprene sleeve or what we would call an anterior closure brace with the side supports, they certainly can. But structurally, it's not changing anything internally to support the meniscus. So it really would be based on their symptoms and if they think it helps.
Is that the same advice you give to the arthritic knees, the last two cases?
Yeah, that's a little bit different. So it depends. In someone who has arthritis and they don't want to do a knee replacement, there are actually braces designed for arthritic knees that are called unloading braces. So you can get a medial or a lateral unloading brace. So for somebody with medial side arthritis, you actually put them in what's called a medial unloading brace, which actually shifts the weight to the lateral side. It actually puts a little bit of a valgus stress on the knee. So that's structurally doing something for the actual problem. And I do use that for my patients who don't want to do a knee replacement to see if we can calm down that bony edema, give that a chance to heal. And some people just wear it consistently, even, long-term, because it makes them feel better.
Right. And then you mentioned, consider cortisone and all of these with question marks. Is that because it's unclear whether it helps, or can it hurt? Can it stop the healing of some of these joints?
Yeah, that's a good question. So in my younger patients, I try to avoid cortisone if at all possible. In older patients who have arthritis, if it's moderate arthritis, and I know if I send them to my arthroplasty colleagues that they're going to say, no, they're not ready, and we've tried PT and they keep having swelling, I do think cortisone can be useful just to calm things down. And I tell every patient, you may get no relief, you may get long-term relief, which could be months, a year, many years. It's very unpredictable. A common question I get when we talk about cortisone is how long does it last? And I always say it doesn't last. It's out of your system in a week or two. What it does is gets the inflammation to go down. And then how long it's going to take for that inflammation to come back is what's going to dictate your relief. And I can't predict that. So I do think it has a role. The reason I try to avoid it in younger patients, and I do always talk to my even moderate arthritic patients about this, is over time, we know that cortisone may have a negative effect on your remaining cartilage. But if you're in that, kind of between zone where you don't really want to get a knee replacement yet, but it's interfering with your quality of life, well, the end game is going to be a knee replacement anyway. So, if it buys you time and over time, your arthritis gets worse in 6 years instead of 7, I think that's a trade-off that patients are willing to take.
And those pictures you showed of the different kind of tears, is there one or two that tend to respond to the viscosupplementation, like the Synvisc, et cetera, or not really?
Yeah, no, so viscosupplementation is for arthritis rather than meniscus pathology. So I would say if you wanted me to pick one, I'd say the degenerative type, only because those are the ones seen with the arthritis, but it's not specifically helping any pain from the meniscus.
Great. I feel like I'm getting my own consultation. I guess no one else has any questions about the knees. Lori, thanks so much. It was a really clear talk, and we really appreciate it. We'll have to have you come back.
Right,
hang on,
great.
There's one other comment here before we let you run here.
Sure.
As a patient for medial lateral bases, I'm not quite sure I can understand this question. I think the question is, do all patients with medial lateral tears or meniscal injuries need to see an orthopedist?
So I don't think they need to. I mean, I'm happy to see a patient at any point along this process, from the day they start having pain and come to see you or call you to the point where maybe a provider thinks they need surgery. But, a lot of patients, if they initially tear their meniscus and they don't have a mechanical block, a lot of them will calm down. I usually tell patients, especially in my 40 and older population, where I know that they're going to probably have at least some arthritis, even if it's mild. I usually tell them, give it, 4 weeks before we get an MRI, because I think about 50% of them will calm down. And, it's not uncommon that someone really insists on an MRI. I decide to get it at 3 weeks. I see them at week 4 and they're like, my pain's better, and they just spent $800, $600 on an MRI if they had just waited, a little bit longer. So I think for me, it depends on how swollen they are. If it's really swollen, if they're catching, clicking, if they feel like something's unstable, all of those mechanical type symptoms, I think you should probably refer to orthopedics sooner than later. If they're just calling and saying the medial side of my knee hurts, I might have twisted it, I'm not sure, I don't remember, then I think you could try a short course of anti-inflammatories, rest, maybe even some physical therapy. Because then when they come to me, if they have a tear, it's like, okay, you've tried all that. So it's live with it or do surgery. But I'm also happy to take the reins and do that initial treatment as well.
Great. Thanks again. And again, if you want to send patients to Lori, she's at Newton-Wellesley Orthopedic Associates, and also as an Epic referral. Thanks so much. Everyone have a nice weekend. We'll see you all. Just a quick correction. We are taking the school vacation week off, but we had the wrong dates on there. That's the 22nd. We'll adjust that and get people out the right information. Thanks. Thanks again. Bye.
Bye-bye.